Endometriosis, ectopic pregnancy, and abdominal pain, including acute abdomen, which your book doesn't go into a whole lot of detail with because it's a surgical problem, but there are multiple things that apply to gynecology and to obstetrics that can be related to an acute abdomen. So an acute abdomen is a surgical emergency. So I want you to at least have some glancing awareness of the deal with that. So today's lecture is kind of organized around pain, one way or the other. Now, for endometriosis first, one of the things that's up on the website, I found this interesting. Influenza virus infection mimicking an acute abdomen in a female adolescent. When we get to talking about an acute abdomen, one of the things that makes general surgery either so much fun or a pain in the butt, depending on your perspective, is that oftentimes it's difficult to chase down what exactly it is that's causing the pain. Okay? And this is a fairly weird reason for pain, but it's on the differential. Influenza infection. Okay, so endometriosis. Endometriosis is a benign condition. It's a common condition. It's defined as when you have endometrial tissue present and growing outside the uterine cavity. Okay, outside the uterine cavity. In other words, the endometrium decided that it's not satisfied just being a lining, and it's going nutso. Okay. Now, one thing that I find weird about endometrial tissue is that when the endometrium sloughs during menses, that tissue is still viable, which means that you can plunk it in a petri dish with the correct nutrition and so forth, and it will continue to grow by itself on its own. Okay? To get most tissues to grow in culture like that, you really have to do a lot of playing with them and messing with them and digging with them. Okay? Endometrial tissue seems to be primed to grow wherever it lands. Okay? Now, how that relates to endometriosis is still being discussed and argued about. Okay. Now, at least 1/3 of women with chronic pelvic pain have endometriosis to some extent, as do a significant number of women who are infertile, who can't get pregnant. And 5 to 15% of women have some degree of the disease. 5 to 15%. That makes it a relatively common condition. Now again, another weird thing with endometriosis is the extent of endometriosis does not correlate with problems from endometriosis, pain or infertility. Okay? In other words, you can have a lot of pain with very little endometriosis present, or you can have an awful lot of endometriosis present and the person not having any pain at all. Okay? So the degree of involvement with endometriosis doesn't correlate with the symptoms, okay? Which is another weird thing about it. Now, endometriosis also, typically your patient is in their 30s, they're nulliparous, and they're infertile. However, endometriosis can occur in infancy, it can occur in childhood, and it can occur in adolescence. Okay. And the pathological problems that it causes are because that endometrium, even though it's jumped ship and located itself somewhere else, it still responds to hormones and to growth signals, and it still bleeds. So if you've got endometrium that's taken a hike and located itself in the abdominal cavity, and then it bleeds on a monthly basis, remember what we said about the peritoneum? The peritoneum is bitchy, okay? It does not do well with inflammation of any kind, okay? And so bleeding into the peritoneum is going to cause inflammation, and it's going to cause scarring. Okay? Now, scarring in the abdominal cavity, if you look in Netter's Atlas and some of these pictures where they actually show everything that's in there, okay? It's not like there's just this room, empty room in the abdominal pelvic cavity. There's a lot of stuff stuffed in there. And the peritoneal membranes, you have a visceral and a parietal surface. So you can start getting membranes that are stuck or adhesed together. They're scarred together. It's like they're welded together. Okay? And this is going to interfere with the mobility then of the organs that are present. Okay? And it's going to lead to obstructions, can lead to pain. Okay? Now, there are 3 leading theories about endometriosis, and I advise you to look at them because I'm going to ask you. We know that genetic predisposition plays a role, but that doesn't seem to be the pathogenesis. Okay, in other words, it seems like this tends to run in families, but that's not the underlying disease process. The first idea, which seems to have a lot of support right now, is the retrograde menstruation theory. Okay? And this is that endometrial tissue, which is normally shed during the time of menstruation, instead of being sloughed and going to the outside, it gets contracted back into the abdominal cavity. Now, one of the historical interesting things about this particular theory is that the old Levitical laws in the Jewish community, okay, were women in the Jewish community supposed to be having sex when they were having their period? Nope. No, okay, and a lot of thinkers have said, wow, you know, they were out in the desert, it was hard to be clean and all this kind of stuff, which makes a lot of sense. Okay, but also, what happens during orgasm with the uterus? It contracts, and if you've got contraction going on, is the squeezing of whatever's in there going to go just one way? Okay, not necessarily, okay, and you can have the potential for stuff being sucked out into the peritoneal cavity. Now, is that what's going on with endometriosis? We don't know, okay, we don't know.
What was the name of the philosophy?
Retrograde menstruation theory. Okay, that somehow the fragments are getting transported out the fallopian tubes, and then they're implanting and growing all over. Okay. Now, the problem is, even though that makes a lot of intuitive sense, the problem is that it doesn't account for all of the different places that endometriosis shows up. For example, even though it's rare, you can have endometriosis on the lungs, in the axilla, on the forehead, okay, which are pretty bizarre, okay? So those would lead you to think that the endometrial tissue is getting transported either by the blood or by the lymphatic fluid, okay? All right, so the second theory is the Mullerian metaplasia theory. You already know that the Mullerian ducts are the ductwork that fuses to form the internal genitalia in the female. The idea is that somehow the tissue within the endometrium, or excuse me, the tissue within the Mullerian ducts gets misplaced, or that tissue in the peritoneal cavity is transformed into endometrium. Basically, it's a mistake during embryologic development. Okay? The tissue transformation that occurs during embryologic development doesn't take place correctly, and so you have endometrium forming in areas where it shouldn't form. Okay? In other words, it didn't pick up and travel. It was there in the first place from the get-go. Okay? That would account for endometriosis showing up in childhood, and infancy, and adolescence. And then the third theory is the lymphatic spread theory, that the endometrial tissues are getting into the lymphatic drainage, and then they are transported out to various pelvic sites, okay, in the lymph. They're getting out of the lymph. Here's my picture. Okay, now, as is usual when the authorities, the academic community, doesn't know what's the reason for something happening is, they will say that it's probably more than one factor. And the nasty thing about that explanation is it's often true. Now, usually endometriosis occurs in the dependent portions of the pelvis. What is a dependent body part? Good thing I asked the question. A dependent body part is usually one that is lower, okay, lower than the heart, for example. When you think of a dependent body part, you think of something that is going to be more influenced by gravity. So the dependent portions of the pelvis would be, the lower portion down here. Okay, so endometriosis most commonly occurs in dependent portions of the pelvis. And if you think about endometrium escaping out the tubes and then settling, that makes sense. Now, some of the specific places, the ovaries, the broad ligament, the cul-de-sac back here, and 2 out of 3 women with endometriosis have ovarian involvement of some type. Okay, so here we have sites of endometriosis, uterus, rectovaginal septum, the tubes, the round ligament, the ovaries, all of the ligaments, okay, the sigmoid colon, okay, the rectus muscle in front, the umbilicus, the rectus muscle in the front, and the umbilicus. Okay, now when you have endometriosis on the ovary and it bleeds, it can produce a cyst-like structure with old blood in it. Now, old blood that's been around for a while turns dark. So these endometriomas, these cysts on the ovary from endometrial tissue, they are sometimes called chocolate cysts. Now, when we get back, we're going to be talking about ovarian conditions. Okay, so we're not going to go into all the different things that can cause ovarian cysts at this point. But an endometrioma is one of the things that can cause cysts or abnormal growth on the ovary. Now, another thing that's weird about endometriosis, which we've already mentioned, but I'm going to say it more clearly here. Endometriosis is benign. Is it abnormal tissue? Yes. Because it's not where it's supposed to be. Is it benign? Yes. It's not real dysplastic. It's not real abnormal. But it's weird because it travels. Usually abnormal tissue that travels is malignant. Okay? Malignant cancer, people tend to die of malignant cancer because it takes over either the space or the resources that the body needs to function. That's what kills people with cancer. Okay? It either takes over the space or the resources that the body needs to function. With endometriosis, it doesn't do that. It doesn't starve the person to death. Okay, so it's not considered a malignant process, even though it travels. Okay. Another thing that's weird about endometriosis is that whereas it is hormonally responsive to the hormonal cycles, if you drop the hormonal level way down, it regresses. Okay, so birth control pills, things like that can be useful. But the weird part is that if you have very high levels of hormone, it also regresses. Now, your book has a chart like this for staging. When you stage a cancer, there are a couple of things you do. You look at how abnormal the cells are, how dysplastic is it? And the second thing you look at is how far has it traveled? Okay. All staging systems are based on those two factors, and I would never make you memorize the staging systems here because they keep changing. Okay, and it drove me bananas when I was in school. Okay. So they have these staging systems for endometriosis. It's kind of a so what thing. I mean, you can go in there, you can do a laparotomy, open their belly up, and see where all the endometriosis is. But it's kind of not clinically relevant because remember we said that the amount of endometriosis doesn't directly correlate with the amount of problems it's causing.
Is it the only way to diagnose it too?
It's one way to diagnose it, yeah. Okay, it's one way to diagnose it. All right, now talking about diagnosing it, okay, what are the symptoms of endometriosis? Chronic pelvic pain. Okay. There are also 3 classic symptoms that go along with that pelvic pain. Okay. One is dysmenorrhea. Two is dyspareunia. And you know what those two mean, or you better. The last one is dyschezia. Now remember, we said that endometriosis can spread all over the pelvic cavity, including into the cul-de-sac, the pouch of Douglas, which is between the uterus and what? The bowels, the rectum. Okay. It can also spread to the uterine ligaments, including the uterosacral ligaments. What sits between the uterosacral ligaments? The rectum. The uterosacral ligaments. So, if you have on the surface of the rectum and the colon itself, okay, So all three of those are places that endometrium can land, or endometriosis can land. So dyschezia means pain with bowel movements. Pain with bowel movements.
You have all three of them, or you may just have like one or two?
This is called the classic triad. In other words, in a classic, typical presentation, you would have chronic pelvic pain and those three.
Is it like hemorrhoids or something?
No. But you may not, Jillian, you may not. Everybody's presentation can be a little different. Okay? No, hemorrhoids are more external. Okay? This is pain when the rectum and the structures contract. Okay? It's not just, hemorrhoid pain is a little bit of a passive sort of pain when you have something actually coming out through past those distended veins. Dyschezia is with the contraction that pushes the fecal material out. Okay. Okay, another sign or symptom that would lead you to expect endometriosis as your problem is spotting. Spotting either before periods or after periods. And even though you may have menorrhagia, or you may have a lot of bleeding, usually the amount of bleeding is diminished, okay, with endometriosis. Now again, in young women, you don't really expect young women to be bleeding buckets with their period anyway. That's usually more menopause or perimenopausal. Okay, so oftentimes, you know, they may not really be able to say, you know, that their periods are less or not. Okay. You can have ovarian pain if the ovary is involved. Okay, so those are symptoms. What's the difference between a symptom and a sign?
Sign means you definitely have it.
Nope.
Symptoms ones that like women will describe that they have, and signs are ones that we observe notice.
Okay, symptoms are subjective. In other words, it's something that the individual feels that you can't measure. Okay, a sign is something that you can either observe or measure. Okay, so it doesn't mean that symptoms aren't real or aren't there. It's just that it's what the patient is experiencing. Okay, so this dysmenorrhea, dyspareunia, dyschezia, that's what they're experiencing. So the signs then of endometriosis would be the things that when you examine the patient, you can detect or notice. Okay? So one of the things would be a tender, fixed adnexal mass. What's the adnexa? The ovary and the tubes. Okay? So a tender, fixed adnexal mass. Why tender? Because they've got all the inflammation going on. Why is it fixed?
Because it's scarred.
Yeah, because of the scarring. Fixed means it's not moving around. Sometimes the uterus also doesn't move around, and it may be retroverted. Remember, if you have a bunch of stuff in the sac behind the uterus, it would tend to scar the uterus towards the rectum. Okay? So the uterus may be fixed and it may be retroverted. It may be tilted back a little bit too much because of the scarring. Now, in addition to endometriosis, there's other things that you have to either consider or rule out. Chronic pelvic inflammatory disease will cause adhesions, okay, and will cause chronic pelvic pain. Chronic or recurrent pelvic inflammatory disease. A hemorrhagic corpus luteum. Corpus luteum bleeds. Benign or malignant ovarian neoplasms. And again, we're going to talk about ovarian cancers when we get back. And then number 4 is ectopic pregnancies. Ectopic pregnancies also cause inflammation. They also cause bleeding. They irritate the peritoneum. Okay. And depending on where the ectopic pregnancy has attached itself, it's going to cause an adnexal mass, okay, especially if it's in a tube. Okay, now as Lisa mentioned, your definitive diagnosis is when you actually go in there and look and you take a biopsy of the tissue. Okay, so to do that, you would either need to cut the belly open by doing a laparotomy, or you would have to stick a scope in through a tiny incision, which would be a laparoscopy. Now, usually in an otherwise healthy young woman, especially if they can rule out ovarian cancer with either ultrasound or with a CA-125, and when they sort of figure, okay, this is not probably ovarian cancer, okay, usually they will make a clinical diagnosis. That means this is what this most likely is, and then they will treat it with birth control pills or other methods there, without going to a laparoscopy or a laparotomy, because those are invasive. Remember, the peritoneum is bitchy, okay? And even though a laparoscopy messes with the peritoneum a whole lot less, you're still messing with it. By the time they go to laparoscopy or laparotomy, usually they are pretty sure that's what they're dealing with, number 1, and number 2, they're ready to try to do something invasive about it. For example, they can use a laser with either kind of lab, okay, to burn the endometrial tissue. Can you see the endometrial tissue within the peritoneum? Yes, you can. Okay, it looks like a bluish, purplish. Okay, it looks a different color than a normal membrane. So they take a laser in there and they burn it. Okay, now that gets rid of the endometrial tissue, so you won't have something cyclically continuing to bleed. But it usually isn't perfect. It's hard to get rid of all the endometrial tissue. You may bounce some off, okay, that then will grow in the adjacent neighborhood. Okay, and if you burn the peritoneum, does that make the peritoneum happy? Mm-hmm. No. So lasering it off can enhance your scarring. Okay, so it's not a perfect fix. Okay, so usually what they try to do is non-surgical types of things. Okay, now in women who have severe endometriosis, sometimes surgery will improve their fertility, but usually they use medical therapy first. Okay, we talked about that. Okay, now there are various ways to suppress menstruation. Birth control pills are the easiest thing at hand, but you can also suppress the hypothalamic pituitary axis in other ways as well. You can use danazol, for example. Okay, and we mentioned that just briefly at the end of pharmacology, that was a steroid, an androgenic steroid that is occasionally used in gynecology. Obviously, you would use things for pain, like NSAIDs.
What does danazol do?
Okay, it increases the hormone level and turns off the hypothalamic pituitary axis. Now, you would think that an intrauterine device would make the whole situation worse. And I believe, I'm not sure about this, but I believe that the old IUDs did. However, most of the new IUDs secrete hormones, release hormones. Their effect is not just on the presence of the IUD. And there are some IUDs that release hormones that make endometriosis less of a problem. In other words, you're applying the hormones right there at the source. Okay, now, one thing that you need to be aware of is that in a young person who has significant endometriosis, you need to check to make sure there are not genital tract obstructions, obvious ones. Okay. And again, this makes sense if you think about the whole retrograde theory. Okay. If somebody has, a hymen or a cyst or something that is impeding menstrual flow, and you can look with a speculum, you can look with a hysteroscope into the uterine cavity. Okay, that's not as invasive as doing surgery. Okay, so in a young person with endometriosis, if you want to preserve their fertility, they may take a quick look to make sure that there's no abnormalities in the tract. All right, adenomyosis. Adenomyosis is when the endometrium moves into the neighbor's house. Okay, instead of packing its bags and leaving the neighborhood, it grows into the myometrium. In this case, with adenomyositis, you have extension of the endometrium into the uterine musculature. Okay. Now, this can cause enlargement of the uterus itself. It can cause heavier bleeding. And it can look very much like uterine fibroids. So dysmenorrhea and menorrhagia, heavy bleeding, dysmenorrhea, dyspareunia, enlarged, boggy uterus. Now, like any other type of dysfunctional uterine bleeding, you need to rule out endometrial cancer. And most, or many, OBGYNs in the past would go, okay, the endometrium doesn't want to play nice. If you're done with the whole having baby thing, let's just get rid of the uterus and we're done with it, okay? You can also alter hormonal cycles with birth control pills. You can also use NSAIDs, IUDs. You can go in there with a laser and ablate the endometrium off the walls, okay? All of which may or may not work. Okay. So, like with fibroids, a lot of times they recommend a hysterectomy, not just because they are misogynistic pigs, but because it may be the easiest way to get rid of the problem. Okay, questions up to that point? All right, let's take a break and then we'll come back and talk about ectopic pregnancies. Ectopic pregnancy, we said that endometriosis was endometrium that wasn't where it was supposed to be. An ectopic pregnancy is a gestation that implants outside the endometrial cavity. So again, you got something that's not where it's supposed to be. Now, in the past, ectopic pregnancy was always talked about in context of surgical emergencies. And part of the reason for that was because most of the time people didn't know that it was an ectopic pregnancy, or didn't know that there was any pregnancy at all, okay, if it wasn't a problem. In other words, it was only identified as an ectopic pregnancy when it caused a problem. So there are some estimates that 1 out of 80 spontaneously conceived pregnancies might be an ectopic pregnancy, and that is hugely high. Okay, so, you know, when I read that, I'm like, wait, I thought that this wasn't common. Okay, well, in the past, we didn't have the pregnancy tests developed to the sophistication that we have them now. Okay? And we didn't have people out there looking for whether they were pregnant before they missed a period and all of this. Okay, so in other words, pregnancies are being diagnosed or being picked up on a whole lot sooner than they were. Okay, so it's like, okay, I'm pregnant. Wait, okay, now we got to figure out where it is that this pregnancy is implanted. Okay, now 95% of ectopic pregnancies implant in the fallopian tube one way or the other. Okay. 95%. However, they can implant anywhere outside the uterine cavity. So, actually, to be excruciatingly correct about it, an ectopic pregnancy is something that's implanted outside the uterine cavity. A tubal pregnancy is a subcategory of ectopic pregnancies, and most ectopic pregnancies are tubal pregnancies. That being said, you can have ectopic pregnancies out anywhere else in the abdominal cavity, and very, very rarely you hear these weird, bizarre stories about an implantation that occurred in the mesentery, for example, and managed to actually develop a functioning placenta, and the kid went to term, okay, with no way out. Okay? You know, you'd have to have a C-section delivery, and even now, with modern medical care, you would be very likely to both lose the mother and the baby because the hemorrhage would be just catastrophic. The mesentery isn't designed to cut off bleeding like the uterus is. Okay. So. Okay, now, again, they're not sure why the incidence of ectopic pregnancy is rising. They think that part of it is we're diagnosing pregnancy sooner and we're picking up on them sooner. It also may be because there is more damage out there to fallopian tubes. Okay, there's an increase in salpingitis. There's an increase in chlamydial infections, pelvic inflammatory disease. Okay, all of these things scar the tubes and can make an ectopic pregnancy more likely, in addition to making infertility more likely. Okay, so the increase of STDs. Also, there is an increase in tubal surgeries. Remember, one of the things that can cause infertility is endometriosis. What's one of the things you can do for endometriosis? Try to get rid of it surgically. Okay, you may have gotten rid of the endometriosis, but you may have left behind narrowed tubes that then would lead to an ectopic pregnancy. So surgical interventions or damage to the tubes. Okay. Now, chromosome abnormalities are not a cause of ectopic pregnancies. Chromosome abnormalities are not a cause of ectopic pregnancies. Now, it can be kind of delicate, because when people lose babies, when there is a miscarriage or a spontaneous abortion, oftentimes people grieve. What we are going to see when we talk about miscarriages and spontaneous abortions is that in the majority of the cases, there was something chromosomally or congenitally wrong with that embryo, which is why the miscarriage took place. But if you say to a person, well, you're better off because this was an abnormal pregnancy, that's not likely to have your client happy with you, okay? Because what they are mourning is the loss of their perfect image. Okay? In a way, it's a little worse with an ectopic pregnancy, because this one wasn't abnormal. It just was it was implanted in an abnormal place. Okay, now there are several things that can happen once you have implantation at an abnormal place. The first is the tube can rupture. Okay? Remember, the tubes are much smaller, and the walls of the tubes are much thinner than the uterine walls. Okay? So the tube can rupture. This usually results in intraperitoneal hemorrhage, okay, which is not a good thing because the individual can bleed to death. What you're going to see with that is symptoms of an acute abdomen, which we're going to talk about next. Okay, and a ruptured tubal pregnancy is a surgical emergency. Second outcome that can occur is that the pregnancy can be reabsorbed. Obviously, placental function and implantation is not going to occur correctly here, and sometimes the whole process just stops, okay, and then the tissue is reabsorbed. The tubal pregnancy can be aborted into the peritoneal cavity. In other words, it can come loose, okay, and float out into the peritoneal cavity. Usually in that case, it's reabsorbed. But again, in very rare, weird cases, you have an abdominal pregnancy where the pregnancy latches onto the omentum or the bowel or the mesentery. And again, the outcomes there are usually not good as well. So you basically have two outcomes: reabsorption or a real medical problem. Now, your signs and symptoms of an ectopic pregnancy: amenorrhea, duh, that usually goes along with pregnancy. Vaginal bleeding, well, that goes along with a threatened spontaneous abortion, and there isn't anything you can do about that. So, nobody's going to be getting excited, jumping up and down at that point. Lower abdominal pain. If you have bleeding into the abdomen, it's going to irritate the peritoneum, and you're going to have abdominal pain. Okay. Now, an acute abdomen, you have severe pain. You usually have rebound tenderness. What is rebound tenderness?
It hurts when it comes back out.
Yeah, you can press down on the abdomen and not have your patient come off the bed, but when you let go suddenly and the abdominal wall bounces back, okay, then they come off the bed. That's rebound tenderness. Rebound tenderness is a symptom in all acute abdomens. Rebound tenderness is a consequence of peritonitis. Now, sometimes you also see ipsilateral shoulder pain. What does ipsilateral mean?
It's on the same side side of.
So on the same side, so if you have pain in the right lower quadrant, ipsilateral shoulder pain would be where? On the right side. Okay, and again, this is a referred pain. Okay. Now, if somebody's bleeding into their abdomen, you would expect signs of shock, hypotension. The abdomen may be distended. Okay. And if you have something that looks like this, or even that looks like this, you're going to have cervical motion tenderness and an adnexal mass. Cervical motion tenderness and an adnexal mass. Now, if you have somebody that you suspect has a tubal pregnancy, but they're not actually crashing on you, okay? The way that you go about confirming your diagnosis with an ultrasound, okay? They look for that gestational sac in the uterus, and they look where it is in the uterus. Okay? They look at the tubes and make sure it's not in the tubes. You also can track this with an HCG measurement. Remember that human chorionic gonadotropin is secreted by the invading trophoblast and continues to be secreted until you're basically done with the corpus luteum. In other words, until the placenta is well established. So the normal levels of HCG rise in a predictable way. With ectopic pregnancy and with twins and with molar pregnancies and other abnormalities, HCG rises, but it doesn't rise in that normal curve. Okay? So one thing they will do to follow these and see what's going on is serial HCG measurements. Now, again, abdominal surgery is invasive, and if you've got a tubal pregnancy that you catch early, the best outcome would be for it to be reabsorbed. You can encourage it to reabsorb by giving the individual methotrexate. Methotrexate is also sometimes, it's a chemotherapeutic agent, really. Okay, it's going to kill cell growth. How do you know whether the methotrexate that you gave worked?
HCG.
You're following those HCG levels, and what should you see them do? Drop. Okay. Now, another lab test that they do along with HCG to monitor the effectiveness or the adequacy of a pregnancy is serum progesterone levels. A normally implanted intrauterine pregnancy will also have a progesterone curve that will be abnormal when the pregnancy is not implanted where it should be. Now, back in the old days, if you had abdominal pain, pelvic pain, and there was no other obvious reason for it, and you expected some sort of gynecological thing, you could be having a slowly leaking tubal pregnancy, or you could have pelvic inflammatory disease. And how would they tell the difference between them back before they had all this sophisticated diagnostic stuff? They would stick a needle into the posterior fornix of the vagina, right up into the cul-de-sac, okay? And then they would aspirate. If they got pus, what was their diagnosis? PID. If they got blood, what was their diagnosis? Ectopic pregnancy. Okay, now, I'm not sure they even bother to do this anymore because they've got much better ways of figuring out what's going on than sticking needles in places that you can puncture things, okay? But that's a way that can be done. Okay, now how do you manage it? Again, with the medical management is with methotrexate or something similar to that. Okay, the surgical management depends on what you have. If you have a large rupture, they may have to remove the entire tube to control the bleeding. If you do not have a patient who's fixing the hemorrhage to death on you, okay, you may be able to go in and slit the tube and remove the pregnancy and then sew the tube back together. Or if it's a small rupture, they may be able to repair the tube. Obviously, if you can do that, that's going to be a better long-term outcome because you have a greater chance of preserving the patient's fertility. And there are various ways that tubal surgery can be done, and that's a little beyond the scope of the lecture here, but they illustrate those for you in the textbook.
Would that cause tubal scarring though, and
Yes.
increase your risk of having another
Yes.
one? So would it be better just to remove it?
You can make that argument. Only 60% of women who have experienced an ectopic pregnancy subsequently conceive. Only 60%, so it significantly reduces people's fertility. You guys have all heard Erin's story. Erin had an excellent outcome from a situation that could have been very bad because basically they initially missed hers, okay, and she had to have one of her tubes removed, and she has had 2 subsequent pregnancies that did just fine, okay, but that's not always the case. All right, now other considerations. Remember, a pregnancy is a pregnancy is a pregnancy is a pregnancy. Okay? So anytime a person has been pregnant, you have the indications for ROGAM if the mother is Rh negative. Okay. Are you going to know with an ectopic pregnancy whether that embryo was Rh positive or Rh negative? Usually not. Okay. If you had a tubal pregnancy that was reabsorbed without being caught as a pregnancy, could she still have been exposed to Rh positive antigens? Yes. Okay. So sometimes there are women who come in and they say, okay, I'm Rh negative. I've never had a baby that was Rh positive. I've never been exposed to Rh positive blood. So therefore, I want to wait with the ROGAM. Okay. You don't know. Okay. Many pregnancies implant and then are reabsorbed. Okay. And that's when they implant in the uterus correctly. Okay. With tubal pregnancies, they implant, they're reabsorbed. Okay. Unless the person is very, very closely tracking what's going on with their physiology, they may be a week or 2 weeks late for their period and not, assume that there's been nothing happened. Okay? So you can never guarantee that every single pregnancy has been caught. That's why they push using ROGAM, like they're scattering flowers in the yard. Okay, sometimes it seems like they are pushing an intervention that's not necessary. Now, the reason why they're pushing it is because you can't always know exactly what the woman has been exposed to. Okay? And remember the whole, my husband is Rh negative. Okay, good. Okay, I love you, honey. Okay, you as a practitioner cannot assume that she has only ever in her life been with an Rh negative man. Okay, so. Okay. Okay, we're done with that. Okay, now let's talk about pelvic pain in general. It's the chapter that talked about dysmenorrhea. Okay, so you may have already read it. Dysmenorrhea and chronic pelvic pain. What I want to talk about now is the portion of the chapter where it distinguishes between acute pain and chronic pain. Acute pain and chronic pain, okay, where there's a little chart that looks like this. It really doesn't make a whole lot of sense unless you look at it very closely. Okay. You need to know what you're talking about when you describe pain, okay? Because the clinical implications are very different for the different types of pain. Acute pain is usually pretty severe pain, and it usually comes on fairly suddenly. Oftentimes, individuals can pinpoint when it started. Now, remember, pain is sort of the ultimate subjective symptom. Can you feel somebody else's pain? No, you can't, even if you're a good politician. Okay? You don't know exactly how that person is experiencing pain. There are tip-offs, like facial expressions, vocalizations, change in heart rate and blood pressure, okay, pallor, shaking, things like this, okay, that are tip-offs, okay, but you can't feel exactly what that person is feeling. Now, you can divide the manifestations of pain, or the aspects of pain, into pain behaviors, pain sensations, and then suffering. Suffering is kind of a term that people assume means pain. We say pain and suffering, okay? Pain is a sensory experience. Suffering is a psychological experience. Okay? Pain is a physical experience. Okay? I smashed my thumb with a hammer and I tore tissue, and therefore my free nerve endings are going nuts. That's pain. Suffering is beyond that. What does this mean? Okay, does it mean I'm never going to be able to be a concert pianist, and so now I'm not only hurting, I'm mourning a loss of function? Okay, suffering can have many dimensions. That's why sometimes they say that animals don't suffer. Is it true that animals don't have pain? Of course not, animals have pain. But the question is, what does that pain mean to them? Do they actually anticipate what the consequences of that pain is going to be? Okay? Do they anticipate losing a loved one? Do they anticipate loss of function? You know, it's thought that they probably don't anticipate, and so therefore their psychological suffering is not the same as what a human would experience. Okay? So, with acute pain, their pain sensation is fairly accurate. Okay? In other words, their pain receptors are telling them, okay, there's some actual damage that's going on here. With chronic pain, their pain sensation may not be accurate. In other words, their brain, their sensory receptors, their spinal cord may be telling them something that's not true. Their pain, their brain, their spinal cord, their sensory receptors may be telling them that they have horrible tissue damage, when in fact they do not. Okay, so the pain sensation is more or less accurate with when you get hit by a train. Okay? With chronic pain, it may not be accurate. Now, the origins of chronic pain have been debated quite a lot and will continue to be debated, but it's thought that the underlying problem is that somehow the pain pathway from receptors to spinal cord to brain gets screwed up. It gets screwed up and starts sending the incorrect information, and that there may be neurotransmitters and other modifications going on there. Acute pain is usually a little harder, or a little easier to deal with. You fix the problem. Okay? You fix the problem, the body heals up, and you go on about your merry way. With chronic pain, it can be very hard to track down the cause, and then even once you fix whatever it is that you find, it may not diminish the pain. Okay? So you have an accurate and an inaccurate pain sensation between the two. Suffering with an acute injury is usually commensurate. In other words, it usually is approximately what you would expect from a broken leg, okay? Or somebody who just got smashed in the face and got teeth knocked out. Okay? With chronic pain, the suffering tends to be exaggerated. Okay? Now that sounds like a really judgmental statement. But anybody who has dealt with chronic pain patients knows what you're talking about here, okay? The suffering, the experience that they are undergoing is exaggerated for the amount of tissue damage they have. Okay, these are the patients who can't function because they have pain, and the physicians can't find anything wrong with them, okay, or find very little that's wrong with them. All right, and then the pain behavior. With acute pain, the pain behavior is appropriate. With chronic pain, it tends more to be inappropriate. Okay, this is where you see drug-seeking behavior, okay, where you see secondary gain. Okay, everybody is nice to me when I hurt, so therefore I'm going to hurt all the time. Or I don't have to work when I hurt, so therefore I'm going to hurt all the time. You see how you've got psychological stuff now impacting a person's behavior? Okay. Now, gynecologic pain occurs in both the chronic variety and the acute variety. An example of the acute variety we've been talking about with ectopic pregnancy. Chronic pain can be caused by endometriosis. It can be caused by a lot of different things. Okay? No matter what kind of physician you are, you tend to dread dealing with chronic pain because it doesn't follow the rules and it's difficult to produce a success. Okay? Right, so most of what you're going to be doing is not dealing with chronic pain, but you are going to be dealing with pain. That's one of the things that midwives do. Okay. Now, you need to be able to distinguish, though, between something that would be an expected situation and something that's an emergency situation. Okay. So, with an acute abdomen, what did we say again were some of the signs and symptoms of an acute abdomen? Rebound tenderness. Okay, an acute abdomen is severe pain. Okay, these are the people that come into the emergency room doubled over, can't stand up, sometimes rolling around on the floor screaming. If it's an acute abdomen, you have to be worrying about hypotension and shock. You also want to look at what can you palpate, what can you feel. What do you hear? With an acute abdomen, you're going to have decreased bowel sounds. Okay? You may have rigidity in some situations. Okay? Sometimes called a board-like abdomen. Rigidity or a board-like abdomen is another tip-off that you have bleeding in the peritoneum. Board-like, rigid bleeding, rebound tenderness, peritonitis. Okay, now, your differential diagnosis here can include a lot of things. So what are some of the things that are on your list for an acute abdomen?
Appendix.
Okay, appendicitis. What else?
Ectopic.
Ectopic pregnancy. What else?
Maybe gallbladder?
Cholecystitis. What else?
PID.
Inflammatory disease. What else? Renal lithiasis, which is kidney stones.
Torsion. A bowel obstruction.
Ruptured ovarian cyst.
An abruption.
Those are always painful though, are they?
Always.
Not always. Sometimes. Come on, guys.
Labor.
It's a low hanging fruit, Dr. Scott. We were trying to get all the other ones up.
Come on, what else is in your belly?
Everything.
Yeah. And just about everything can go wrong too.
Maybe some kind of like colon diseases, like or whatever Serena has.
Diverticulitis and all of the other
Itises.
irritable bowel diseases, like Crohn's disease. Okay, what else?
Whatever.
Cancers.
Yeah, cancers don't usually present as an acute abdomen.
Endometriosis.
What else?
Adenomyosis.
Yep. Adenomyosis. What else?
What about an aneurysm?
Aneurysm.
And a partridge in a pear tree.
Stomach.
Ulcers?
Ulcers. Particularly if there are perforated.
Peritonitis?
Okay, peritonitis is usually usually goes along with one of these. It usually doesn't just show up on its own.
Obstruction.
Pancreatitis of any kind.
Ruptured spleen.
Some sort of infection, like food poisoning or something.
No, food poisoning doesn't produce an acute abdomen. Not unless it's accompanied by appendicitis, which occasionally happens. But there are some infections that can imitate acute abdomen. Influenza can do it. And in young children, sometimes strep can do it.
Is this specifically female, or is this in general?
General, yeah, but you're more focused on female. Why would you have
I
male?
was thinking prostatic issues.
No, prostatic issues don't usually produce an acute abdomen either. Okay. Prostatitis.
Really, really bad gas.
Exceptionally
In
bad.
the context of a bowel obstruction, perhaps, because you get a bloated bowel. Okay. Intussusception. You know what intussusception is? Yes, no. It's when you have your bowel is round. Okay, it's when a section of the bowel slips into another section of the bowel.
Is it like
Okay,
overlap?
which kinks the blood supply. Okay, and causes a section of the bowel to die.
Lovely.
Yeah, lovely. All right, so how do you go about differentiating between these things? Let's play. I'm a resident in the ER.
I don't know, throw a dart at a board.
And sometimes
So
the nurses think that the residents throw darts at a board.
Lab work.
Okay, what?
Lab work.
Okay, lab work, what are you looking for?
Well,
CBC or
CBC, CMP.
Okay, first of all, especially if you have symptoms of shock, you want a CBC to see how bad you're doing here. Okay, as you are fluid resuscitating them. Okay, what else?
ultrasound.
What else is on the CBC?
White blood cells.
White blood cell count. Okay, why are you looking at that?
Infection.
Which of these may have an infectious component?
A lot of them.
Okay, appendicitis for sure. Okay, cholecystitis maybe. Okay, PID for sure. Okay, diverticulitis maybe, but not usually too much. And then this, you might have an elevated white count or lymphocyte count. Okay, all right. Ultrasound. An ultrasound is kind of cheating, but that's basically what we do now.
If someone's in like severe pain, that's
We're gonna figure out what's going on.
Right, you can figure out, you can look without opening them up. They used to do what was called an exploratory laparotomy, which meant we've got an acute abdomen here and we know this person's gonna die, but we really don't know why, so we're gonna open him up and look and fix what we find. Okay, now they can use an ultrasound and figure out a little better what they have. So what can you see with an ultrasound? What would you see with appendicitis?
It's a rupture.
enlarged appendix.
You would see an enlarged appendicitis, you might, or a large appendix, you may see stones or fecalus in the appendix. You would see the swelling of the wall, you may see rupture, you may see abscess formation of the peritoneum around it. Okay, with ectopic pregnancy, you would see the gestational sac someplace it shouldn't be. What would you see with cholecystitis?
Stones and then.
You would see stones in the ductwork, you may see dilated ductwork. Okay. By the way, what is the difference between appendicitis pain classically and other types of pain?
Lower right quadrant.
Pardon?
It's not in the lower right quadrant.
Okay, where does it start? Classic appendicitis pain starts around the umbilicus and then travels to the right lower quadrant. Now, did anybody tell the appendix that it had to reside in the right lower quadrant? No, so sometimes the appendix isn't there, which is what makes general surgery so much fun, okay? It used to be said if you weren't opening up patients about 25% of the time and not finding an appendix, inflamed appendix, you weren't operating enough for appendix, okay? Because it was that easy to miss, okay, and that common. Okay, now, cholecystitis. What characteristics of pain do you have with cholecystitis more typically?
Upper gastric pain, shoulder, referred shoulder pain.
Epigastric, referred to the right shoulder. Okay, it tends to occur in waves, which is what colic means. So colicky pain. Okay, it may come on instead of instantaneously. It may come on, you know, in an increasing manner. It may be related to like eating a fatty meal. Okay, there may be inflammation or infection of the gallbladder. There may not. PID.
You're gonna see a bunch of inflamed tissue in the peritoneal cavity.
Yeah, and PID is usually going to be lower abdominal pain, and it tends to be more, instead of sharp and stabbing, it tends to be more dull, aching kind of pain. Okay. Renal lithiasis or kidney stones. What kind of pain are you going to have with that?
I'm saying colicky.
Again, colicky, renal colic, because you've got those peristaltic waves trying to push that stone, okay, down. What else might you see with kidney pain, kidney stones? Well, flank, CVA, tenderness. It may radiate down into the groin, okay, into this area. Okay. You may have bloody urine if the stone is scraping the lining of the ureters. Okay, ovarian torsion.
Usually unilateral pain.
Yeah, it should be more unilateral. Okay, and torsion of any type, whether it's testicular torsion or ovarian torsion, tends to be excruciating. Okay, and ovarian torsion is pretty rare because the ovaries are kind of pretty much hung where they are. Testicles, that's a little more of a deal there. Okay. All right, bowel obstruction.
That is, you can have some diarrhea stool, but mostly like, it's constipation, but maybe like diarrhea, like fecal, small diarrhea, fecal matter.
Okay, bowel obstruction, you can have changes in bowel habits, okay? You may have constipation, you may have intermittent diarrhea, you may have a bloated bowel, okay?
Vomiting.
With vomiting, and you may have, you know, very thin, runny sort of stuff because things are not getting past the obstruction, okay? What might be in the vomit if you have a bowel obstruction? Fecal material. Okay. Now with cholecystitis, it's possible to have bile in the vomit. Okay. With bowel obstruction, it's possible to have fecal material. With the bile, you can see it because it's gold. With the fecal material, you can smell it. Okay. All right, ruptured ovarian cyst. Murder? What do we see with that?
Unilateral pain.
Yeah, usually unilateral pain. Okay. We could probably put in here middle schmerz. What is middle schmerz?
Sounds like a Jewish term.
I remember saying it, but I
German.
forget what it is.
Okay, it's it's the pain that some people have with ovulation. Okay, now, usually, okay, that's not acute enough to be acute abdominal pain, but occasionally you have somebody who just goes off the wall with it, okay? Ovulation can also be caused by Pliny regnon, which is also a German term, and it means little showers. And that's just the bleeding that you have. Occasionally there's a small amount of bleeding with the rupture of that cyst. Okay, placental abruption,
Vaginal bleeding.
vaginal bleeding, okay, and, you know, all hell breaking loose, okay. Labor, miscarriage, okay, if you are a resident and you diagnose an acute abdomen and your person is in labor, they will never let you forget it.
Well, the nurses will laugh at you for the rest of your residency.
Yes, okay. How about diverticulosis or inflammatory bowel disease?
You have dysfunctional bowel movements.
Again, bowel changes. This one tends to be, especially when it's the lower colon, okay, it tends to be more on the left side than the right side, okay. This can be accompanied by inflammation, peritonitis, abscess formation, okay, so it can look an awful lot like appendicitis on the other side, okay, or it can be more subtle and look a lot more like a bowel obstruction, okay, or it can cause chronic diarrhea where a person has to go all the time, okay, when you're talking about Crohn's disease or ulcerative colitis. With ulcerative colitis, there also may be blood in the stool. Okay. All right, endometriosis we talked about, ruptured aneurysm.
That's
First of all, what's an aneurysm?
it's a bulge in.
It's a bulge in
That's wall.
an artery is the one you worry about, okay? And usually with a ruptured aneurysm in the abdomen, it's an abdominal aortic aneurysm, okay? Can you feel a normal aorta? Yeah, you can if you got somebody skinny enough, okay? If you're pressing right in here and they're skinny enough, it's fairly easy to press the aorta between your fingers and your backbone and you'll feel it, okay? So if you can feel something pulsating in there, should you wig out? Depends on how big it is. How big should a person's aorta be? About the size of their thumb. Okay. If you've got something massively bigger than that and it's pulsating, okay, you need to call in help yesterday. Okay. All right. And yeah, a ruptured aneurysm, you have somebody dead fairly quickly. A rupturing aneurysm, okay, you may have enough time to get somebody there. And this is where an ultrasound can be life-saving because you figure it out fairly quickly and you can get them into surgery quickly. Okay. All right, ulcers. What kind of pain do you have with ulcers?
It's like heartburn.
It can be heartburn-like, it can be epigastric pain, it can radiate to the shoulders or the back. Sometimes there's vomiting with ulcers. What would you see with a bleeding ulcer in the vomit? You might see bright red blood, but you're more likely to see blood that has been partially digested, which will look like coffee grounds. A perforated ulcer tends to produce a rigid abdomen. Okay.
What does that
Well,
mean?
say the other
It's
kind of bleed.
split? What is a perforated
Where it's like gone
ulcer?
through the.
Where it's gone through, it's gone all the way through the wall into the
Oh my
peritoneal
God.
cavity. So now you're dumping
Acid.
stomach contents and acid into the peritoneal cavity. And if the perforation also ruptures arteries, you will have bleeding into the peritoneal cavity as well. All right, pancreatitis.
Tea-colored urine.
Well, I can.
Tea-colored urine, okay. Before that, pain, okay. Epigastric pain, especially severe pain that radiates to the middle of the back. And pancreatitis can be mistaken for a back problem. Okay. And in this case, you need an intensivist, not a chiropractor. Okay. Pancreatitis is associated with gallstones. It's also associated with alcoholism. You can have diarrhea or throwing up here, but pancreatitis usually buys you a stay in the intensive care unit because it screws up a person's chemistry big time. Okay, their calcium chemistry will be off. A lot of times their potassium chemistry is off. Their acid-base chemistry may be off. Okay, and in addition to that, your pancreas makes your insulin and makes your digestive enzymes, so your sugar status will be screwed up, and then, you know, being able to properly digest and absorb food, you know, it's pancreatitis is a pain.
It'd be high, your sugar levels would be higher.
Maybe or maybe not. It depends on whether the insulin is being secreted or not, okay, what your body's response is to it, whether your body's dumping a lot of glucose into the system. Ruptured spleen. Okay, maybe left-sided pain. Spleens tend to refer to the shoulder also. Okay, and again, you would have rebound tenderness or a rigid abdomen with a bunch of blood being dumped in to the abdomen, and of course you would have severe hypotensive shock when you have, you know, an immediate rupture. Okay, in tussoception, you're going to have symptoms that are very similar to bowel obstruction or maybe diverticulosis. Okay, the infections, that would be way down the last thing on your list. It's like if you've ruled out everything else and you can't find anything else, okay, that's when you might start doing cultures and doing, you know, more of the weird sort of stuff. Okay. Okay, questions up to this point? What do you do about it?
An infection?
Depends on what it is. Okay, what do you do about appendicitis?
Take the appendix out.
Surgery, you take the appendix out. Okay, is it possible for the appendix to rupture and the person to live through it? Yes, it is, but it usually causes peritoneal scarring because what the peritoneum does is it wraps around the appendix and forms an abscess. Okay, and abscesses are not good because the immune system can't properly get to the infection. Okay. Ectopic pregnancy, what do you do?
Surgery.
Go in and take the tube out. Okay. Cholecystitis. Okay, you go in there and you take the stones out and you do an intraoperative cholangiogram where you put dye into the ductwork to make sure you got them all. You sew the thing back together as well as you can, and you usually put a drain in there so that the gallbladder, the gall will drain out. Okay, the bile will drain out until the whole thing heals back together properly. Okay. Kidney stones, what do you do?
Pass them, or you can get the radiology back, or not radiology, whatever that back thing is.
Yeah, lithotripsy, okay, where they use sound waves or yeah, they use ultrasound waves
Bust up the stone.
to bust the stone. Okay, now, way back when dinosaurs walked the earth before we had our kid, my husband was an engineer for medical equipment, and he never wanted me to have an ultrasound because his reasoning was, hey, we use ultrasounds to bust up kidneys, you know, why are we, you know, blasting a developing baby with ultrasounds? Okay, now the level of energy that you're using in the two different types is completely different. But anyway. Okay, where am I?
Ovarian torsion.
Ovarian torsion, what do you do about that?
Go in.
Surgery.
Correct it.
Okay. Oftentimes with torsion, the gonad will have had the blood supply cut off, which is what is causing the pain. So oftentimes the gonad has to be removed. Okay. Bowel obstruction.
Depends
Go
on
and
what
take
it
it
is.
Depends on what type it is, and there are 48 bazillion different kinds of surgery that they do for that. Okay. Ruptured ovarian cyst, what do they do for that?
Surgery.
Surgery or nothing. Okay. Placental abruption.
Get that baby out.
Get that baby out. Okay. Diverticulitis, inflammatory bowel disease. diet management, medical management. Okay, if you have abscess formation in a toxic patient, you might do surgery, but okay, ruptured aneurysm, surgery, surgery, surgery. Ulcers. Okay, if you've got a perforated ulcer, you have to do surgery. Okay, otherwise you have other options. Okay, pancreatitis. Okay, again, usually they try to medically manage this because the pancreas is difficult. You can't sew on it. Okay, so this is usually medically managed in the intensive care unit. Ruptured spleen, surgery, surgery, surgery. Infections, get over it. Intussusception, surgery. Okay, they have to go in and they have to take the area of dead bowel out and then sew the two ends back together. Okay, now, this is an overview. I'm sure that I have forgotten some things that are on the differential, but the take home here is, look at how many of these are either obstetric or gynecologic. Furthermore, some of these things can and do occur during pregnancy. Appendicitis, cholecystitis, and kidney stones do occur during pregnancy. Okay, so even though some of the rest of these may not be associated with pregnancy, some of them are or can occur during pregnancy. So you need to have some idea, of that in the mix as you're going about figuring out, okay, is my pregnant lady here simply whiny and can't handle her round ligament pain? Or is there something seriously going on here? All right, questions?
Something else that we've seen in practice too with acute abdomen is HELLP syndrome.
Yep. Okay, you want to explain to them why?
I don't really understand why. I know it has to do with the liver, that's radiates pain to epigastric, but that was the first presentation with severe epigastric pain. They gave her, I don't remember the name of the drug, it's like Benadryl, the hospital grade Benadryl, and sent her home because they thought it was GERD. And, or they thought it was something, I don't know.
Probably thought it was pregnancy-related reflux.
Pregnancy-related reflux, something. And then she came back the next day with full-blown liver enzymes out the wazoo and really super low platelets, and she had an emergency C-section.
I'm glad you brought that up because I did forget that. Is it LLP or is it LLP? Okay. So acute abdomen symptoms, especially late in pregnancy, you need to, don't forget eclampsia. So yes, thank you. That would have been an important one, yes. Okay. All right, we're done for today.